Why do I need to be on video?
For the time being, just check and
Okay. Where is the presentation of the abstracts?
Hello, we have our
Hi, good morning. Am I audible?
Shobit, can you help us?
Yes, sir. Yes, sir. You are audible.
Okay.
Video is fine as well.
Yes, sir.
Okay, fine.
Dr. Sobit? Dr. Sobit?
Doctors, we'll be going live in 2 minutes.
Okay, sure. Okay.
Akash, all set from your side?
Yes, sir.
Dear participants and judges, we'll be going live in 1 minute. Akash, just announce when we are live.
Okay.
Let me push it. Beauty under it.
Hello, Shobit.
Doctors, we'll be going live in 30 seconds.
Okay.
Akash will be announcing.
Okay.
We are now live.
Doctors, we can start now.
Lot of scientific papers which had to be selected, and it was a long process, and we came up with the e-posters of the highest standard, and we have got the best of the judges for them. We are fortunate enough to have Dr. Sunit Mendiratna, Rohtak, and Dr. Rajendra Singla from Sarvodaya Hospital. So they will be judging a broad mark out of 10, and at the end of it, all the first three okay. So are we audible again?
Yes, sir.
Okay, fine. So we have got all the chairpersons with us. I can see Dr. Rajendra Singla, Dr. Sunit is here, Dr. Arvind Srivastav is there, and we also have Kiran Bala ma'am with us. So for this session, I'll be soon handing over the charge to Dr. Sunit and the other judges to carry forward the session. But we need to record their marks out of 10 so that in the end we'll aggregate and accordingly decide on the winners. I'll request all the presenters to please stick to their timelines. We only have 5 minutes allotted for e-poster and 2 minutes for the discussion. So any deviation from that timeline might be counterproductive for your scoring. So with that, I welcome you all and hand it over to Dr. Sunit for further chair.
Good morning. Am I audible? We have all the presenters ready. As is been informed earlier, we need to stick to our timelines, and we can start with the first presenter, please.
Good afternoon, everyone. Am I audible?
Yes, please go ahead. Dr. Rahul, please proceed.
Good afternoon, everyone. I'm Dr. Srinivas Akilla. My poster for today is a prelim study on utility of bedside optic nerve sheath diameter in neurosurgical practice. Introduction. The optic nerve sheath is a continuation of dura, and beneath it, the subarachnoid space continues along with the optic nerve. Therefore, when there is a rise in ICP, it gets transmitted to the optic nerve sheath and eventually resulting in swelling of the optic nerve sheath, optic disc, and having papilledema, which can be measured ultrasonographically. Increase in ICP causes distension of the optic nerve sheath in the bulbar segment due to the hydrostatic transmission of intracranial CSF pressures to CSF and subarachnoid spaces surrounding the optic nerve. And this process happens long before the development of papilledema. So this can be measured using an ultrasound. So our aims and objectives is to evaluate the role of optic nerve sheath diameter as a substitute for ICP measurement. And we have included patients with clinical features of raised ICP and excluded the pediatric age group. When it comes to the methods and materials, OSND, the optic nerve sheath diameter was measured using a 5 to 16 megahertz linear transducer probe, and the patient is placed supine, and the transducer probe was applied with gel over the closed upper eyelid. The optic nerve sheath diameter was measured 3 mm posterior to the globe, which appears as hypoechoic band. Here we can see that we see two hypoechoic bands which demonstrate the subarachnoid space surrounding the optic nerve, and this is the space which increases when there is a raised ICP. And 3 measurements are taken, and the mean is calculated for the 3 measurements, and this is done in both the eyes. So here we can see the diagrammatic. First measurement is taken 3 centimeters. The D1 measurement, dimension 1, is taken 3 millimeters. 3 millimeters from the globe posteriorly or the optic disc, and there we take the measurement of the second measurement, D2, which is the diameter of the optic sheath. And this is also taken. We have to keep in mind that we have to take the outermost point of the hypoechoic band that is seen on both sides of the optic nerve. We have performed this on 15 patients, choosing having a heterogeneous group of patients having all neurosurgical cases, and we have found that they had clinical features of raised ICP such as headache, vomiting, and diminution of vision. And we have measured the optic nerve sheath diameters in both the eyes, and we have taken a mean of the optic nerve sheath diameter, and we have scored it here. And then we have also, for some patients, we have measured the optic nerve sheath diameter after they have undergone the neurosurgical procedures. When it comes to the results, out of 15 patients, we have seen that the raised optic nerve sheath diameter is seen in 10 patients, which is almost 67%. And in that 10 patients, there was who had raised optic nerve sheath diameter. They also had a CT evidence of hydrocephalus. And the rest of the 5 patients had normal optic nerve sheath diameter, and even in their CT scans, we couldn't find any evidence of hydrocephalus. To come to conclusion, USG measurement of optic nerve sheath diameter is a useful bedside tool, which is non-invasive and can be done serially, showing real-time results for raised intracranial pressure in neurosurgical patients. However, more studies with larger number of cases are required to reach a meaningful conclusion. Thank you.
Thank you, Dr. Rahul, for this presentation. What I would like to know is, this is a very subjective test, I will say.
Yes,
so
ma'am.
how sensitive and specific it is?
Ma'am, according to the literature, it is 92% specific, more than 90% specific and sensitivity. Even though it's subjective, that's why we take 3 measurements and take a mean out of it.
Have you, in literature, do you have any evidence in particular group of patients, like where it is more helpful? Like patients with IIH or patients?
Ma'am, basically, we are trying to substitute this to measure the ICP, because all the measurements of the ICP are invasive procedures.
Invasive, right.
So this is a non-invasive procedure which can be done bedside and at our convenience. So we are trying to do this and substitute the invasive procedures for measurement of ICP and monitoring as well.
Thank you.
Thank you.
Any other question from the audiences, please? Okay, thank you, Dr. Srinivas.
Thank you, sir.
We move on to second speaker, Dr. Harkaran Singh, who will be speaking on to assess the delirium in the patient of brain tumor. Dr. Harkaran, please.
Good afternoon, everyone.
Start.
Yes.
You are not audible. You are not audible. Harkaran, you are not audible.
Yes. Sir, am I audible now?
No. Now your screen is shared now. Okay. Speak.
Yes, sir.
I'm not audible. Is it not
Am I-
audible?
Sir, I am audible now.
Or now you are audible?
Yes, please go ahead.
Go ahead.
Good afternoon, everyone. My topic for presentation is to study the occurrence of delirium in the patients of the brain tumor. Introduction. The incidence of the delirium is estimated to about 9.5 to 15% in the patients suffering from the brain tumor. To date, only a small number of studies on the post-operative delirium are available, which have included the patients, and those have really included the patients who have undergone intracranial surgeries. And also these studies have been hindered by the methodological limitations of the retrospective design. Identification of delirium constitutes an important parameter of assessment, not only in terms of neurological improvement, but also for other ancillary associations which can have impact on the patient outcome. In this study, our objective is to identify delirium in the patient in relation to the brain tumor and association of delirium vis-a-vis location of the brain tumor.
इसका टाइमर ठीक नहीं चल रहा था
नहीं जो हाँ टाइमर 2 मिनट का हाँ
And aims and objectives are to identify delirium in the patients for the brain tumor, to identify influence of the location in the various lobes of the brain and its association with the level of delirium. Material and methods included. The study design was a prospective observational study for a period of 4 months. The patients who were above 18 years of age with brain tumor were included in the study. Exclusion criteria included previously operated cases of brain tumor, the comatose patients, severely aphasic patients interfering with the assessment, and the patients who were not willing to consent. The tools used for the assessment were the mini-mental statement examination, that is MMSE, then enrichment, agitation, and sedation score, and then confusion assessment method in intensive care unit. It is a preliminary study, and the total number of patients studied till now included 16, out of which 2 patients developed post-operative delirium, and it came out to be a percentage of about 12.5%. Various tumors included in the study were the frontal lobe space occupying lesion, then temporoparietal as well, frontoparietal as well, optic nerve as well, then the CP angle space occupying lesion, and the olfactory groove space occupying lesion. Among these patients, RAS was used as the deciding factor for the further assessment of delirium, in which the patients who were having RAS less than 2 were included for the assessment of delirium. And after subjecting to RAS, the patients were further assessed with CAM ICU criteria, and only 2 of those patients met the criteria who fit in the with the criteria of the delirium. The 2 patients who tested positive for delirium were, one was the 22-year-old male patient with right frontal as well, whose MMSE score was 26, and RAS at 24 hours post-surgery came out to be -1. Patient was subject to CAM ICU assessment, on which patient was found to be suffering for delirium. The other patient was 40-year-old male patient with the frontal glioma, who also tested 24 on our MMSE, and RAS was +2. Patient was further assessed with CAM ICU and found to be suffering for delirium. Delirium settled after 3 days without any active medical intervention. So conclusion is, in the preliminary data available from the 16 patients, only 2 of the patients were strictly found to be suffering for delirium. Both of these patients were suffering from the frontal lobe tumor who developed delirium after 24 hours of surgery. Further study will help us in arriving at a definitive conclusion with regard to development of delirium in the patients of the brain tumor and particular association with the location of the brain tumor. Thank you.
Sir Srivastav, sir, you need to unmute yourself. It's on a mute.
Sorry. Dr. Harkaran, this was a good thing that you observed a new thing in a brain tumor, which is normally taken as a psychiatric element or anything else. But you have proved that this is a delirium. This is a good thing to is shown for the neurosurgical patients, and it should be included in the armamentarium for the patient's condition.
Yes.
Any question? Any question? So no question. So, okay, thank you, Dr. Harkaran.
Thank
We
you.
move on to next speaker, Dr. Amol Mittal.
Hello. Am I audible?
Okay, yeah, Amol, yeah. Full
And
screen
my
can
screen
be.
is visible? Yeah.
Yeah.
Good afternoon, everyone. So today my topic of presentation is delayed subarachnoid hemorrhage after transfemoral surgery for pituitary adenoma, a life-threatening complication. Myself, Dr. Amol Mittal, I am a senior resident in Department of Neurosurgery at RML Hospital, New Delhi. So this 30-year-old gentleman initially presented to urology OPD with complaint of generalized weakness, left flank and back pain. On examination, pulse was 98 per minute, BP was 140 by 90 millimeter of mercury, saturation was 100% with increased skin pigmentation, central opacity, increased glucose level, increased urine-free cortisol, increased plasma ACTH level with hypothyroidism, and dexamethasone test was not suppressible. CECT abdomen was done, which is suggestive of bilateral adrenal hyperplasia, and PET-CT was suggestive of bilateral adrenal gland with physiological tracer uptake. Contrast MRI was done for that patient, which showed a cellular mass of 6 by 5 by 5 millimeter, which was T1 hypointense, T2 heterogeneous hyperintense, and heterogeneous contrast enhancement, suggestive of pituitary microadenoma, Hardy-Wilson grade 2 and NOPS grade 1. So patient was planned for transnasal transfemoral surgery, and post-operative course was uneventful. At 3 months follow-up, patient had a residual pituitary adenoma of 4 by 4 by 3 millimeter on the left side, which was T1 isointense, hyperintense on T2, and heterogeneous contrast enhancement, Hardy-Wilson grade 2A and NOPS grade 1. Patient was reoperated via transfemoral route for the residual lesion. The intraoperative tumor was soft, whitish, and minimally vascular. The arachnoid membrane sunk down post-adenoma excision without any evidence of CSF rhinorrhea and bleeding. And cellular floor was repaired with fat, nasoseptal flap, and fibrin glue. And post-operative cortisol value showed a declining trend. Immediate CT scan was done, which was unremarkable. Post-revision surgery, patient was discharged in a vitally stable condition on thyroid supplementation, glucocorticoid replacement, and oral hypoglycemic agent, and a single antihypertensive. However, on follow-up in OPD, patient presented with mild headache, which was holocranial, dull aching, and non-radiating, and relieved on taking medication. 20 days later, patient presented with sudden onset severe headache, followed by loss of consciousness and altered sensorium with generalized tonic-clonic seizure. On examination, BP was 70 by 40 on inotropic support, pulse was 120 per minute with decerebrate posturing, and pupil were bilateral, constricted, and non-reactive. CT scan was done, which is suggestive of diffuse SAH, thick with intraventricular hemorrhage with obstructive hydrocephalus, and an urgent EVD was inserted. However, we were not able to resuscitate, and patient died thereafter. Azrani et al. Defined delayed postoperative complication as any complication occurring 48 hours or more after transfemoral surgery for pituitary adenoma. Probable hypotheses include forceful traction with massive curettage, sudden decompression of the cellular floor with traction of the vessel, and formation of the pseudoaneurysm. Jin et al. Reported that even in cases with no aneurysm at preoperative evaluation, such as our case, slow glowing pituitary adenoma may attach to the surrounding structure, possibly leading to pseudoaneurysm and bleeding. A recent systematic review of literature identified 18 cases in which the patient had delayed formation of the pseudoaneurysm post-transfemoral surgery for pituitary adenoma. Similar findings were reported by Matsuno et al. And Kuronayaki et al. They speculate an indirect injury to an artery caused by the traction due to descent of the capsule during tumor debulking, which have been the cause for the subarachnoid hemorrhage. It usually includes the cavernous, clinoidal, and ophthalmic segment of the internal carotid artery. The aneurysm can occur in 3 weeks following the injury, and the rupture rate for such aneurysm is very high, with a 30 to 50% mortality rate. Treatment is endovascular, which include flow diverter, detachable coil, stent graft placement, and liquid embolic onyx, and it is preferred over a direct surgical repair. So a pseudoaneurysm of anterior circulation is a life-threatening post-operative delayed complication after transfemoral surgery for pituitary adenoma, and probable etiologies include forceful traction with massive curettage, sudden decompression of the cellular floor followed by retraction of the vessel, and erosion secondary to the usage of the rigid cellular floor reconstruct. Thank you.
Okay. Very nice presentation and very nice case. But one thing I'll suggest you that you don't disclose your place of work, because this is we are marking the place. So don't disclose the name of your place where you're working. Okay.
Exactly. Were you able to get a angiography post-op?
No, sir. Till the time, sir, we resuscitated and we inserted the EVD. We were not able. The patient was highly unstable on noradrenaline and dopamine, so we're not able to shift the patient to angiography to get the CT angiography post-op in the immediate post-operative period after the ictus.
Okay. Any question? Other question? Thank you, Dr. Amol. Thank you.
Sir.
Dr. Sunit, continue.
Yes, please. Can we have the next presenter, please?
Dheeraj.
Thank you. Can we have the next presenter, please? Dr. Dheeraj?
Dr. Dheeraj.
You may start, please.
Am I audible?
Audible, you know. Share your screen. Share the screen.
Yes, sir. Sir, is it visible now?
Yeah, okay. Now you continue. Now time starts now.
Yes, sir. A close syndrome. I'm presenting a case of close syndrome, spinal AVMs and its syndromic association, the role of careful clinical examination. Spinal arteriovenous malformations, AVMs, are abnormally developed blood vessels leading to clinical symptoms and signs secondary to mass effect, ischemia, and hemorrhage. Spinal AVMs represent about 25% of spinal vascular malformations. Many of these patients have associated anomalies leading to various syndromes which are often overlooked. Spinal AVM may be a part of a syndrome rather than isolated disease. These associations can have an influence on patients' outcome also. A 19-year-old national level para-Olympian swimmer referred with a provisional diagnosis of cervicodorsal AVM with chief complaints of bilateral lower limb weakness since 7 months and urinary incontinence since 20 days. On neurological examination, there was spastic quadriparesis with sensory loss, and power was 4/5 in bilateral upper limb and 1 to 3/5 in more in right than left lower limbs. Deep tendon reflexes were 3+ in bilateral knee joints and ankle joints. Planters were bilaterally extensors, and the treatment plan was embolization and surgical excision, a combined approach. And patient underwent 2 sittings of embolization before surgical excision. We first took the patient for endovascular embolization, and at that time we observed this third image, which is showing the hypoplastic fingers. So we asked the attendant, and we were told that it is present by birth. So we carried out the endovascular embolization of the feeders. But while planning him for surgical excision, we examined him thoroughly and found the associated morphological features such as multiple lipomas over the back. The arrow is showing a large lipoma over the back. And the second image is showing epidermal nevis. And the third image is atrophy of the upper limb and hypoplastic fingers. So it was from our part, we missed these features during our first sitting of endovascular embolization. And the investigation and management on MRI T2 scan, there were large flow voids in the epidural space involving C5 to D1 levels. This arrow is showing flow voids. And the endovascular images are the pre-embolization images and the post-embolization image. The first image is showing The catheter is lying in the right thoracocervical trunk, and after embolization, there is diminished filling. And the second image is showing left thoracocervical trunk. The long arrow is in inferior thyroid artery, and the arrowhead is deep cervical artery. And after embolization, there is diminished filling. And the third image is left vertebral. There is a feeder, which after embolization, the filling has been diminished. The patient was discharged with a satisfactory outcome, and he was advised rehabilitation, and the power in both the limbs were 4/5, and he is in our follow-up. And in conclusion, many patients of spinal AVM may be actually a part of some syndrome, which can be anticipated by careful clinical examinations only. Our case closely fitted into the closed syndrome, but such features occur parallelly in various other syndromes, such as Proteus syndrome, Klippel-Trenaunay syndrome, and Cobb syndrome. But by examining, he was closely fitting into closed syndrome, which included congenital lipomatous overgrowth, vascular malformation, epidermal nevi, skeletal and spinal abnormalities, occult spinal dysrhythmism, and increased risk of pulmonary embolism. The close is an acronym of congenital lipomatous overgrowth. V stands for vascular malformation, E is for epidermal nevi, and S is for spinal abnormalities. Thank you.
Thank you, Dr. Dheeraj. Any question? So, Dr. Dheeraj, you mean to say that all the cases of, if you find all these things, lipomatous overgrowth or vascular malformation, you should go and investigate spine also for AVM. What is your message?
Sir, I was unable to hear the question, sir. Can you please repeat it?
Okay. Am I audible?
Yes, sir. Yes, sir.
So, with all these associated symptoms, if you find during examination, you find the first thing, then spinal AVM should be considered.
Sir, every spinal AVM patient should be thoroughly examined. We learned this. We learned this from this case, and we should look clinically as well, and after before investigating the patient.
You should go for all these things apart from that. The thing is that the proper examination of the patient is very important, because you missed in first thing while you are investigating for the spine, you missed the epidermal nevi and all the lipomatous growth. So it means that as a resident, you should always examine the patient thoroughly. Okay?
Yes, sir.
Right.
Yes.
That's the message.
Can I ask one question?
Yeah, sure.
Dr. Dheeraj, what is the implication in terms of the management?
Sir,
if you have discovered all these abnormalities, does your line of management change?
Ma'am, we can grade such patients on classification grade. There is one grading, Anson and Spetzler grading, and so this patient falls in grade 3, which is juvenile malformation, and the treatment of such group is ma'am a combined approach usually, because these lesions involve the posterior element such as bones, subcutaneous tissue, and paraspinal muscles. So the management changes according to the grading, and which involves combined clinical and investigations.
Okay, thank you. Thank you, Dr. Dheeraj.
Thank you, sir.
Now I request Dr. Vinita Balakia to present her deliberation. Dr. Vinita, please. She'll be speaking on evaluating role of still fundus photography in neurosurgical practice. Am I audible?
Yes, sir.
Share the screen.
Yes, sir. Am I audible, sir?
Yeah.
Good afternoon, everyone. I am presenting a poster on evaluating role of still fundus photography in neurosurgical practice.
You are not audible. What happened?
Network issue, sir.
Network issue. Sunit, we see the timing. Time is going on. Yeah.
Yes,
You
sir.
can continue.
Introduction. Fundus examination using Directofthelnoscopy, a highly useful investigation in neurosurgical practice, providing information regarding intracranial CSF and vascular dynamics. Use of Directofthelnoscope is gradually declining. Through this study, we explored the use of handheld fundus camera and its usefulness. Aims and objectives: study of fundoscopic still image findings in cases of hydrocephalus, subarachnoid hemorrhage, and intracranial tumors, and correlation with GCS score. Materials and methods. It was an observational study of 1 year duration in which 30 patients of intracranial tumors, 30 patients of hydrocephalus, and 40 patients of SAH were included. Mean time taken to click the fundus image was 15 seconds. The procedure was done by first year resident levels, and Bosch handheld fundus camera was used. Results. In cases of SAH, 62% patients were found to have papilloedema, 3% cases were found to have subhyaloid hemorrhage, and 35 patients had normal fundus findings. In cases of hydrocephalus, 33% patients had normal fundus findings, while 67% had papilloedema. And in cases of intracranial SOL, 50% had normal fundus findings, 33% had optic atrophy, and 17% had papilloedema. Higher Friesen grade of papilloedema correlated with poor GCS score and poor clinical outcome. These are the images showing normal fundus. On the left, there is subhyaloid hemorrhage in a patient with DACA aneurysm presenting with SH. Then there is papilloedema Friesen grade 5 and contralateral papilloedema and ipsilateral optic atrophy in a patient with right sphenoid wing meningioma. Conclusion. Digital fundus photography has been found to be a very useful tool in evaluating neurosurgical patients with combined ease and quality over direct ophthalmoscopy. Eliminating close patient contact, no need of mydriasis, easy storage of image and comparison with previous pictures, elimination of inter-observer differences and easy reproducibility. Thank you, sir.
Thank you, Dr. Vinita. So, do you find any difference between direct ophthalmoscopy and fundoscope in this fundoscope?
Yes, sir. Yes, sir. Direct ophthalmoscopy is a bit cumbersome to use, and the images can't be stored. And inter-observer differences can also not be eliminated. While in fundoscopic image findings, the image can be easily compared with post-procedure and pre-procedure pictures.
Right. Any question from the audiences, please?
Can I ask one question?
Yeah, sure.
Yes, ma'am.
Dr. Binita, have you compared the direct ophthalmoscopy and the still fundus photography in your patients? What was there any difference?
Yes, ma'am. We
or-
have compared. Yes, ma'am. In collaboration with GNAC Hospital, we have compared, ma'am.
In these patients, what results you have projected? Did you do the direct ophthalmoscopy also?
Yes, ma'am.
So you have not projected what was the comparison? What they
ma'am, to cross check and
similar or-
confirm. No, ma'am. To cross check and confirm our findings, we referred the patients to ophthalmologist in GNAC Hospital, ma'am, for direct ophthalmoscopy.
That is okay. But what was your results?
Same findings, ma'am.
So these still fundus photography was compatible, showed the same thing as the direct ophthalmoscopy.
Yes, ma'am.
Okay, thank you, Dr.
Okay,
Vinita.
thank you.
Thank you, sir.
We move on to next speaker, Dr. Mahesh Mahajan, will be speaking on association of sagittal bending of optic nerve and its influence on visual impairment in cell region lesions. Dr. Mahesh, please.
Sir, am I audible?
Yes, yes. Share the screen, Mahesh.
Sir, am I audible?
Yeah. Yeah.
Myself, Dr. Mahesh. Good afternoon, everyone. Myself, Dr. Mahesh Mahajan. I would like to present a poster presentation on association of sagittal bending of optic nerve and its influence on impairment of vision in cellular region masses. Despite of adequate decompression of cellular region masses via transcranial or transnasal route, there are several other factors which affect the visual outcome. This includes the duration of symptom, fundus findings, and visual evoked potentials. In material and method, patient of cellular region masses with visual disturbances underwent ophthalmological examination with visual acuity, field of vision, pre-operatively and post-operatively. And in radiological examination, the patient were undergone T2-weighted thin sagittal cuts for optic nerve canal bending and angle with 3 Tesla MRI, both pre-operatively and post-operatively. This is the image which shows the formation of optic nerve canal bending angle between the intracanalicular part and the intracranial part. So the angle formed between intracanalicular and intracranial part is around 52 degree pre-operatively. And in the same patient, post-operatively, the angle formed between intracranial part and intracranial part is 29 degrees. This is the data sheet. This is the data sheet which is compiled for 10 patients, of which 8 patients were of pituitary macroadenoma, 2 were of tuberculum cell meningioma. The procedure under they went were open as well as transnasal transplantar tumor decompression. 2 patients underwent TNTS, and rest of the 8 patients underwent transplantar tumor decompression. These are the findings. The inference of this finding is if the optic nerve canal bending angle is more than 40 or 45 degree, the visual outcome after surgery is same. And if the second inference is if the angle is more than 36 degree, the visual impairment in this patient starts. The early prelim report of 10 cases suggests that in addition to the factor attributing to the visual loss, as mentioned in literature, preoperative visual impairment is found if angle is more than 36 degrees, and it is irreversible. The outcome is irreversible if the optic nerve canal bending angle is more than 45 degrees. Post-operatively, after tumor resection, the transnasal or transcranial method, returning of optic nerve canal bending angle to the normal values prognostically predicts the improvement in visual status and fall in visual impairment score. The conclusion, apart from the conventional concept of visual deterioration, there is a significant association of sagittal bending of optic nerve and its influence on visual impairment in cellular regions. So this is a new concept where we should look for optic nerve canal bending angle preoperatively and postoperatively as a surgical tool for outcome.
Okay, thank you, Dr. Mahesh. Question? Any question? So, Dr. Mahesh, did you see the normal person's ONCA?
Yes, sir, we did, sir. It was around 10 to 15 degrees, sir, in normal patients.
But if the visual acuity is already deteriorated there, does it have any impact?
No, sir, we had control cases as normal patient with visual acuity normal. And in pathological patient, we included cellular supracellular. Sir, according to literature, they says if the angle is more than 20 degree in cellular region masses, then the visual impairment starts. But we have found that if the angle is more than 36 degree, then it starts. So there are more 8 cases to be done to confirm the findings. This is just a pilot study.
Okay. Any question?
In this study, you had controls also?
Yes, ma'am. Yes.
How many controls? But you have not projected in the results.
No, ma'am. Currently, I have not mentioned. We have just mentioned the pathological findings.
That's okay, but these need to be compared with the normal controls how
Yes, ma'am.
to really say that it is a significant thing and
Yes.
it has some prognostic value.
Yes, ma'am.
Ma'am, can I ask a question? I'm Dr. Neera.
Yeah, Dr. Neera, yeah, please.
Good morning, sir. So we see this bending in IIH cases also who develop this visual obscurations. So whether we could do such a thing in IIH? Because
Ma'am, in
it's a
IIH,
phenomenon, a raised ICP causing a pressure onto the optic nerve. So we get a vertical.
yes, ma'am. In IIH, the bending is usually bidirectional. It is in coronal plane as well as sagittal plane. We have included just the sagittal cases, ma'am, in cellular supracellular masses. We have not included the coronal bending of optic nerve.
You have not included?
The coronal bending, the lateral bending of optic nerve. We have just included the sagittal bending of optic nerve.
So the bending is there, it will be in the sagittal as well as the coronal plane. Now, what's the difference?
No, the pathology is because he has analyzed only the cellular supracellular masses and ONBC relation.
So what I was
It
wondering, sir,
happens-
we could also do that in IIH. That
Yes, ma'am,
yeah,
sure,
you can.
Post treatment, whether if we look at the bending, if that also improves.
Yeah,
Yes, ma'am.
that's
We can include, ma'am.
Thank you, sir.
Thank you,
okay.
ma'am. Thank you, sir.
Dr. Kiran Bala, you continue with the next speaker.
Yeah, I don't have the list. Who is the next speaker, please?
Shankar Ram Chaudhary, Dr. Chaudhary.
Dr. Chaudhary, please present your paper. Is he there?
Yeah, he's there. Shankar, share the screen.
Yes, sir.
You're not audible.
Any problem in sharing screen? It's not visible, not
Share
audible.
the screen. You are not audible.
Dr. Shankar?
Yes, yes.
Okay. Now your screen is seen. Continue.
Yeah.
Yes.
Make it slide presentation. Yes. Thank you.
My poster presentation on non-vestibular, non-trigeminal, unusual head and neck schwannoma. Introduction. Schwannoma are slow-growing encapsulated benign tumor that can originate from any nerve covered with the sheath of Schwann cell. Vestibular nerve schwannoma is most common cranial nerve schwannoma, followed by trigeminal nerve schwannoma. Head and neck schwannoma arising from the non-trigeminal, non-vestibular source are extremely rare and constituting only less than 0.8% of all schwannoma. In this article, we have analyzed our experience in the management of these rare tumor over a 2-year period. Material and methods. Retrospectively, data analysis 2019 and 2020. Complete clinico-radiological and surgical record were analyzed. Follow-up data collected from the hospital record and telephonic follow-up. A total of 6 such cases were found. There is image showing the one case of the third nerve schwannoma, 3 cases of the 6th nerve schwannoma, 1 case of the 12th nerve schwannoma, and 1 case of the 10th nerve schwannoma. The incidence of the non-trigeminal and non-vestibular schwannoma is less than 0.8%, but in our study, incidence was 10.71%, which was significantly higher. Among the rare schwannoma, intraoperatively oculomotor nerve and vagus nerve schwannoma were clearly identified, but rest cranial origin of the schwannoma could not be identified intraoperatively. Post-operatively, 1 case of the 6th nerve schwannoma, vagal nerve and hypoglossal schwannoma was improved. In conclusion, in spite of the 8th nerve schwannoma being common, chance of other cranial nerve involvement are significantly high. Accurate pre-operative diagnosis on the basis of the MRI scan is possible, but confirmed evidence can only be given by intraoperative demonstration of the site of the origin of the lesion. In the large size tumor, involvement of the multiple cranial nerve is common, hence accurate diagnosis is possible only intraoperatively. These tumors should be completely excised with the microsurgical technique with minimal morbidity. Recurrence is rare after complete tumor excision and should be aimed during management of this lesion. Thank you.
Okay, thank you, Dr. Shankar. My suggestion, did you go for intraoperative neurophysiological monitoring also to identify 6th and 3rd nerve?
Yes, sir.
You identified 3rd and 6th nerve physiologically also.
Only, sir, anatomically and physiologically, but we could not, sir, do intraoperative, sir, no monitoring, sir.
Because my suggestion is that you should go for
yes,
physiological monitoring to identify that exactly this is 3rd or 6th nerve.
Ji, sir.
Okay, because it can come out with the other cranial nerves also at the same time.
Ji, sir. Ji, sir. Thank you, sir.
Okay, thank you. Dr. Kiranmala, any question? Your comment?
I'm just want to know how you suspect clinically about this, that these are schwannomas.
Ma'am, just patient, one case of the 3rd nerve schwannoma present with the proptosis and loss of extraocular muscle movement.
Plus MRI findings.
Yes, ma'am.
So in MRI, you cannot really localize what you said, that in all the nerves.
Not on the basis of MRI, we could not identify site of origin. As in the last schwannoma, there is a multiple cranial nerve close to the tumor, but exact origin of the tumor could not be found on the basis of the MRI.
No special MRI sequences can identify.
No, ma'am. No.
You must have discussed with the radiologist.
Now, recently, I'll tell you, recently the people are coming with an MR neurography.
Yes, sir.
Yeah,
Hello?
there's a lot of advancement in MRI techniques now, so we should be able to identify on the basis of imaging.
Yes, ma'am.
So, what Dr. Arvind is saying, sir, can you share that?
Neurography.
Neurography, okay.
MR neurography.
Yes, I think that should help to identify pre-operatively.
And intraoperative neurophysiological monitoring will give us the idea that this is exactly which nerve is this.
Yeah.
So it should be included in the study. Yeah.
Thank you.
Yes, sir. Yes, sir. Thank you, ma'am. Thank you, sir.
Okay, now we move on to next speaker, Dr. Rajshit Mittal. Is it there?
Yes, sir. Sir, am I audible?
Yeah.
Yes, you are.
Sure. Continue.
Good afternoon, everyone. Neurosurgical patients with cardiac implantable electronic devices poses several challenges for the neuroanesthetist. There is a limited literature regarding the anesthetic management of these patients. So hereby we present our experience of managing 3 such patients: 1 patient with automatic implantable cardioverter defibrillator and 2 patients with pacemakers who underwent neurosurgical intervention at our institute. First patient presented with left frontotemporal abscess and underwent burr-hole evacuation and a subsequent craniotomy and abscess evacuation. He had AICD implanted for dilated cardiomyopathy with ejection fraction of 25% and a recurrent ventricular tachycardia 7 years back, with battery replaced 2 years ago. He had a past history of left middle cerebral artery stroke with decompressive craniotomy and cranioplasty 2 years back, coronary artery disease with stenting, and hypertension with single kidney. Another case presented with aneurysmal subarachnoid hemorrhage with Huntington's 3, WFNS grade of 1, and modified Fisher grade of 3. He underwent emergency craniotomy and clipping and had pacemaker inserted for complete heart block with 2 years back. He had a past history of CAD, hypertension, and right renal artery stenting. The third case underwent craniotomy and excision for right frontal tuberculoma. She had pacemaker inserted for complete heart block 2 years back, and she was a controlled hypothyroid. All the 3 patients were pacemaker dependent. And in the case 3, MRI could not be performed as pacemaker was not MRI conditional. We made a pre-operative optimization preparation plan in consensus with the CID technicians, the cardiologists, and the neurosurgeons. The sources of electromagnetic interference were identified by us. CID technician was pre-operatively ensured the proper functioning and the setting of the device and was available in the OT to monitor, reprogram, and manage potential device malfunction. Cardiologist for optimization of cardiac comorbidities and intraoperatively for transvenous spacing. Neurosurgeons was advised to use bipolar cautery, to use a monopolar cautery in short burst, and to place dispersive paths near the shoulders. We had arranged defibrillators, transvenous spacers, and emergency cardiac drugs in the OT, and the CID was deprogrammed. The anti-tachycardia and the rate adaptive functions were disabled. The pacemaker was turned to asynchronous mode with heart rate set to 80 per minute in all cases. All the cases were performed in the supine position. For burr evacuation, we gave a scalp block and sedation with fentanyl. And for general anesthesia, we gave scalp block and induction with ketofol due to its cardiostable properties. Besides routine monitors, we measured the invasive blood pressure, central venous pressure, arterial blood gas analysis, bispectral index for depth of anesthesia, and neuromuscular monitoring for general anesthesia cases. We did monitoring of pulse oximetry and arterial BP waveform to ensure electromechanical synchrony. For ECG, pacing mode was turned on, and left in an internal jugular vein guided CVP insertion was done using ultrasound. Intraoperatively, we gave a prophylactic dobutamine infusion for patient with dilated cardiomyopathy. Intraoperatively, no hemodynamic instability was noted in any patient. All the patients were extubated and shifted into neurosurgery ICU for postoperative monitoring. Monitoring continued in the postoperative period with ABG and serum electrolytes 4 hourly. All the devices settings were restored after 2 hours, and the infusion was tapered over the next 2 hours. The discussion. As we have seen, in our patient, we had various comorbidities. Neurosurgical patient with CID can have comorbidities in addition to the neurosurgical and cardiac rhythm pathology. And various additional neurosurgical pathologies such as acute subarachnoid hemorrhage can cause cardiac and electrolyte anomalies, which can alter the pacing of our CID devices, can increase the risk of first arrhythmias, second cardiac hemodynamic instability, and most potential catastrophic event, the cardiac arrest. So as a result, a thorough preoperative evaluation is necessary for hemodynamic management of such patients. This becomes more important, especially during emergency, when we may not have the technician or the cardiologist available for optimization. So knowing the functionality of these devices and their idiosyncrasies in the OT is important for both the surgeons as well as the anesthetist. Simultaneously, saturation and IVP waveform analysis are important because during cautery use, the ECG may get hampered. So we have to use this to know that electromechanical synchrony is there. Another thing is during CVP insertion, we should use an ultrasound guided left-sided insertion technique so to avoid potential damage to the CID leads. We were fortunate enough to have all the cases in supine position, but the placement of pacing leads and magnets can be a challenge especially during prone and lateral positions. In the end, a multidisciplinary individualized approach, a meticulous preparation, monitoring, minimizing electromagnetic interference, along with prompt management of hemodynamic instabilities are successful for management of these patients. Thank you.
Okay, thank you, Dr. Rajni. Do you have any shortcoming for the use of drill in these cases?
So drills can be used in these patients. So they can be used in these patients. But again, we have to continuously monitor the invasive blood pressure and the saturation and the ECG in these patients. There is no such contraindication for using drills in these patients.
Because if you have implantation in the heart, they normally say that the drill has to be avoided just because of development of arrhythmias.
So for that was the reason we have turned the asynchronous mode in our pacing on to avoid the disturbance, and we have disabled the anti-tachycardia function. So for that thing, we have disabled all the functions of the CID and did a continuous vigilant hemodynamic monitoring.
If the patient develops arrhythmia during their course, then?
So if a patient develops arrhythmia, the first response to be to tell the surgeon to stop the whatever procedure is happening. Secondly, we have to turn the device back to their original settings. And if still the arrhythmia is not controlled, then we have to go with the ACLS algorithm and manage the arrhythmia or the cardiac arrest, whichever is happening.
Okay, thank you. Any question from the audience, please? Your question? Dr. Sunit, your comment? Dr. Mehdita?
I just want to make a comment. Is there a cardiologist standby while you're doing the procedures?
Yes, sir. There was a
Yeah.
standby cardiologist for transvenous spacer if in case the device malfunctioned.
Okay.
Thank you.
Thank you. Thank you, Dr. Mittal.
Thank you, sir. Thank you, sir.
Now, Dr. Singla, you continue. Dr. Singla. Dr. Rajan Singla. Is he there? Is he there?
Sir, I think Dr. Rajan Singla sir is not there
Not
right
there.
now.
Okay, Sunit, you continue. Sunit. Okay, I'll continue.
Yes, sir. Please continue.
Now I invite Dr. Karandeep Singh to speak on intraoperative central diabetes insipidus during aneurysmal clipping surgery, a diagnostic dilemma. Please continue. You're not audible.
Is my voice audible?
Now it's audible. Yeah, continue.
Good afternoon. I'm Dr. Karandeep Singh, Senior Resident in DRMD Urinary Anesthesia Department. I'll be presenting a case report on intraoperative central diabetes insipidus during aneurysmal clipping surgeries. Central diabetes insipidus is a known complication associated with the pituitary surgeries, more often occurring in the post-operative period. But DI during aneurysmal subarachnoid hemorrhage is rare. But intraoperative DI during aneurysmal clipping surgeries has not been reported yet. So here we describe a case of intraoperative DI in a patient undergoing aneurysmal clipping surgery, which posed a challenge for both diagnosis and management. A 55-year-old female with no comorbidities presented with subarachnoid hemorrhage due to rupture of left middle cerebral artery aneurysm, posted for clipping surgery, aneurysmal clipping surgery. But preoperatively, there was a sudden neurological deterioration, which prompted NCCT head that revealed a left temporoparietal bleed with surrounding edema, which was possibly a rebleed due to aneurysmal rupture. Patient was taken up for aneurysmal clipping surgery and evacuation of hematoma. Patient was taken in, on emergency basis. 2 hours into the surgery, just prior to the clipping, polyuria was noted with the urine output more than 700 ml per hour. CVP was on the lower side and PPV was on the higher side, which both of these values indicated that patient is hypovolemic. ABG was done, which showed serum hypernatremia. Serum osmolality was also on the higher side. Urine specific gravity was done, which was found to be on the lower side, 1.003. DI was suspected and treatment was initiated on those lines. Free water replacement was done. IV fluid was changed from 0.9 to 0.4% normal saline and vasopressin infusion was started. After 40 minutes of initiation of the treatment, the urine output decreased and serum sodium levels also had a decreasing trend. Post-operatively, the patient was shifted to neurosurgical ICU on mechanical ventilation and continued vasopressin infusion. And vasopressin infusion was then tapered off after resolution of polyuria and hypernatremia after 18 hours. This is a post-operative CT scan done 6 hours post-operatively that showed a residual hematoma with an infarct in the left MCA territory extending to thalamic hypothalamic area and cerebellum. And this is a pre-operative NCCT head that showed a left MCA territory massive bleed, possibly a rebleed with edema and compression of the contralateral ventricle. So as we can see that there is no infarct apparent on the preoperative CT, and post-operative CT there is a infarct in the thalamic hypothalamic area. So diabetes insipidus during aneurysmal surgery is uncommon and was not anticipated by us. So as an anesthetist, we faced a diagnostic dilemma in finding out the cause of intraoperative polyuria and diabetes insipidus. First of all the common causes of polyuria were ruled out. Osmotic diuresis by mannitol, since hyponatremia was not present, it was ruled out. IV overload was ruled out by CVP and PPV monitoring. Hyperglycemia was not there, and any drug that induced or precipitated DI was not used. That was ruled out. In our case, the polyuria with increased serum osmolality and hypernatremia together with a low specific gravity, pointed towards a diabetes insipidus, and responsiveness to vasopressin confirmed our diagnosis that it is a central diabetes insipidus. Diabetes insipidus after aneurysmal cerebral hemorrhage may be caused by damage to the supraoptic or ventricular nuclei of the anterior hypothalamus, which are supplied by perforating branches of ACA and ACOM. So in this patient, the intraoperative DI was due to an evolving ischemic injury to the hypothalamus, which could be present at the time of rebleed or previously present, but which was not apparent on the preoperative scan. However, post-operative scan, when it was done 6 hours post-procedure, the infarct in the thalamic hypothalamic area was clearly evident. So to conclude, I want to say that development of DI during anal surgery is uncommon and was not anticipated by us. So initially, when polyuria occurred, all the common causes were ruled out. So the cause of intraoperative DI in this case was possibly a pre-existing ischemic injury of the hypothalamic region that subsequently involved to infarct, which was revealed only on the post-operative scan, and our intraoperative period just happened to be in between. So it was not anticipated by us. So to conclude, the possibility of diabetes insipidus should be anticipated in all the cases of intracranial bleed and infarct, and including in cases of subarachnoid hemorrhage, to enable a prompt diagnosis and appropriate management. So care for vigilance is of a paramount importance during such surgeries. Thank you.
Any question from anesthetist? Is there any anesthetist present, please?
Anesthetist is present, but that will be a bias because he's our anesthetist. So no comments. No comment.
No comment. No comment.
I have a question. When you had increased urine output in the preoperative period.
No, sir. In preoperative period, there was no increase in urine output.
Why are you calling it a? So prior to surgery, the was 700 ml. You said that is what the amount was.
Sorry, sir. Please repeat your question, sir.
You said just prior to surgery, the urine output was 700 ml.
No, not prior to surgery. After initiation of the surgery, 1.52 hours after the initiation of the surgery, the polyuria was noted. Prior to surgery, urine output was under normal range, sir.
Prior to clipping.
Prior to, I said prior to clipping into the procedure.
Okay. So is it possible that since the CT already showed an infarct on the second day, the ischemia was already present, which you will not pick up on the scan, because
sir, the CT was not done on the second day. It was done post-operatively same day, and the preoperative CT was done when the patient's neurological condition deteriorated, which showed a yes, sir.
So my question is, when the CT already shows an established infarct,
yes,
the
sir.
event of ischemia happened prior to the surgery, much earlier. When it already shows an infarct, it's at least 24 hours into the procedure.
In our case, when the preoperative CT scan was done, which showed a massive bleed, and the case was taken on emergency basis, the difference between the pre-op and post-operative CT was approximately 12 to 18 hours, and our infarct developed in that period.
Thank you.
Okay, thank you. Thank you, Dr. Karan. Now I request
Dr. Karan, just one question. How in the literature, how frequently this is reported?
Ma'am, the occurrence of diabetes insipidus associated with the subarachnoid hemorrhage has been reported in multiple times, but the intraoperative event, ma'am, it has not been reported. There is a one case report in 2021 by Dr. Bittel of AIMS. He reported an intraoperative DI, but that was preceded by a Sheehan syndrome, which was a missed diagnosis.
Okay, thank you.
Okay, next, now move on to next speaker, Dr. Deepak Chaudhary.
Yes,
will be speaking on a study of association between XRCC7 gene, polymorphism, and glioma. Please, Dr. Deepak Chaudhary.
My screen is visible?
Yeah, full screen. You can put it a full screen.
Yes, sir. Good afternoon.
You're not audible. You're not audible. Not audible.
Hello, hello. My
Hello?
voice
is now audible.
Now audible.
So I'm starting my presentation. The topic of my presentation of study of association between XRCC7 gene polymorphism and glioma.
Make it full screen.
Make it full screen.
Dr. Deepak, put it on
So
slide
as we
share
all
mode.
know that ionizing radiation.
Dr. Deepak,
Can't hear you.
Dr. Deepak, you have network issue.
Where is Deepak? Deepak,
Sorry, I'm
network
not getting
issue.
actually. I'm already on screen sharing mode only, and
No, you are not audible, and your screen. We want you to give the full screen.
Put it on slide share mode. Dr. Deepak.
now my screen is.
No, it is not.
Oh no. Oh
Yes.
yeah. Now you are
you can
seen. Screen. Share the screen.
Sir, I have shared the screen.
No, we are not able to see it.
Mr. Yogesh, please help. Mr. Yogesh.
Deepak, you have already sent it to them.
No, sir, I have not sent it. I am sharing from my laptop only.
Okay, so then share.
Okay, sir.
Right.
If you have any problem, then you can continue later on.
We can take up the next.
Next one,
That
so
will be fine.
Deepak, you said yourself. Okay, now I request Dr. Abbas Kumar. Dr. Abbas Kumar, I can see him on the screen. Dr. Abbas.
Dr. Abbas Kumar.
I can see you on the screen, but not audible.
We can call next speaker, sir.
Dr. Abbas, yeah. Now
Yes,
I call.
Yes.
Who is this?
Dr. Abbas Kumar is there.
Okay. Dr. Abbas, share your screen. The host, please help him.
Mr. Yogesh.
Any problem, Dr. Abbas, in sharing the screen? You're not, no, you are not audible also.
Am I audible now, sir?
You are audible now.
Okay, sir. I'll be sharing the screen right now.
Share the screen, yeah. Focus it. Focus is out of focus.
One second, it's opening. So can you see the screen?
The images are very much blurred.
It is blurred. It is blurred. What happened?
Yes, sir. Now it is clear.
Not clear, sir?
Yeah, it is.
Okay, sir. Good afternoon, everybody. Myself, Dr. Abbas. I'll be presenting a rare case, a very rare entity which is known to the medical literature also. It is Gapo syndrome. I'll be presenting with the abstract. The Gapo syndrome is extremely rare condition where Gapo stands for G stands for growth retardation, A stands for alopecia, P stands for pseudo-anhedonia.
Please move your slides ahead.
Abbas sir, please put out it. Yes.
No, it is not. It is blurred. Totally can't read anything. No, no.
Little better, but still blurred.
Blurred. The host, please. Have you sent it? Have you sent your slides? Abbas, have you sent your slides?
Yes, sir. I sent my slides. Send my slides to Abhishek.
Host, please.
Yes.
You share.
Mr. Shobhit. Shobhit. Mr. Yogesh.
What is here? What happened?
1 minute, sir.
Agash, please help.
Should we go back to Dr.
Deepak.
Deepak? If
Deepak,
he's
are you
ready?
ready? Deepak, are you ready? Deepak?
Yes, sir. I'm ready, sir.
So you can share. You can start with your deliberation. Yeah.
Yes, sir. Yes, sir.
Abbas, you fix up your problem.
Sir, my screen is visible or not, sir?
Yeah, it is visible.
My screen is visible, but come to the first slide.
Yes, sir. This is my first slide only, sir.
No, no.
No,
it's
this
not
is,
first.
I'm seeing the result. I'm seeing the result.
Sir, on my laptop, this is my first slide actually.
This is on screen. It is result.
Doctor, I will help you. Doctor, please go to stop sharing from your end and
Drop,
go
huh?
to the first slide.
Okay.
Again slide.
Yeah, share it again.
Okay.
No.
Yeah, now it's there.
Now it's there. Yeah. Okay. Continue. Continue.
Good afternoon to all. The topic
Make it
of
full
my...
screen.
Now can I start?
Sure.
Can you make it full screen? Slideshow.
Yeah, he's done it. It's taking time.
Already
Anyway,
done.
continue.
So topic of my today presentation is study of association between XRC7 gene polymorphism and glioma. So as we all know that glioma is the most common CNS tumor and its etiology is still unclear. We believe that ionizing radiation and genetic alternation are its probable risk factors. So by these radiation and genetic alterations, these DNA damages can be single-stranded, double-stranded, non-homologous type, homologous type. So all these DNA damages which are done, these are repaired by certain DNA repair genes like XRCC7 gene, XRCC1, 3, RED51. So in this study,
Advance. Sorry, Deepak. Advance the slide. Slide is not being advanced.
Sir, I have already advanced the slides.
Your first slide is on the screen. Advance the slide.
Doctor, please click on escape button.
Escape
Doctor,
button.
yeah, in your keyboard.
I have done escape, yes.
Yes. Can you click on yes? Yes. Just click on if you want to go forward. Just click on the slides.
Okay.
Okay.
So this is my second slide.
First slide. No. Yes. Now it has come.
Okay. So DNA damage can be single stranded, it can be double stranded, it can be homologous, non-homologous type. So all these DNA damage which occur, these are repaired to maintain the genomic stability. These are repaired by certain DNA repair genes like XRCC1, XRCC3, XRCC7, RED51. So in this study, we are studying XRCC7 gene. The full form is X-ray cross complementing gene, which is a non-homologous type of end joining double-stranded break repair gene. So we hypothesize that polymorphism of this repair gene, XRCC7 gene, can be associated with risk of glioma. We have done this study because only scanty literature is available on the gene association with glioma. Only Wang study is available, Wang-Lee study. So our is a case control study. In this, we have taken 30 cases and 30 control. We have taken sample as blood samples, and XRCC gene polymorphism was studied using PCR RFLP method. Our inclusion criteria was all histologically proven glioma cases, and control was cancer-free patients. And exclusion criteria, we have not taken any recurrent tumors. Below is the picture of our machinery which we have used. This is the PCR polymerase chain reaction machinery which amplify our desired base pairs. Second is the agarose gel electrophoresis unit. In this, after restriction enzyme, in which this XRCC genotypes are break into GG, GT, and TT. We run in this and we identify the GG genotype, which our patient are GT and what our patient are TT type. And third picture is gel documentation system in which we document our G genotypes. Then this is the gel electrophoresis picture. In after restriction enzyme digestion, if we are getting one band, then that is GG type. If we are getting 3 bands, that is GT type, and 2 bands, that is TT type. Then our results. In our study showed that statistically significant difference in distribution of GG and TT and GT genotype among cases and control. In cases, out of 30 cases, we have observed that GT and TT genotype are common in 28 patients. And in control group, GT and TT are we found in 18 patients. So frequency of GT and TT is more in cases as compared to control. Similarly, allele frequency of T is more common in cases as compared to control. Our p-value is 0.003, which is statistically significant. Also, our study showed that the proportion of GT and TT genotype are higher in male patients as compared to female patient, and age group between 40 to 60 patients. Below chart shows the same. So our conclusion is that XRCC7 gene polymorphism, GT and TT variants, might be a risk factor for genesis of glioma. Once its involvement in genesis of glioma is validated with larger studies, it can be used as a tool in gene-based therapeutic intervention. This gene may also be used in future in predicting prognosis of the patient and also to classify the glioma. Like recently, WHO has introduced molecular classification. Limitation of our study is that we have taken only 30 cases and 30 controls. So our results need to be validated with larger sample size. Thank you, sir and ma'am.
Okay, very good, nice presentation, Deepak. Any question for this? Any comment? Thank you, Dr. Deepak.
Thank you, sir.
So
Thank you.
with this, now we move on to Dr. Abbas. Are you ready? Dr. Abbas?
Abbas, sir?
Are you ready?
Yes, sir.
Okay, sure. You are not audible, no.
Sir, unmute yourself.
Am I audible now?
Yes.
Now you are audible.
Thank you, sir. Good afternoon, sir. Good afternoon, ma'am. Good afternoon, everybody. Today I'll be presenting a very rare entity, very rare case of Gapo syndrome. Gapo syndrome is an extremely rare entity where Gapo stands for the acronym where G stands for growth retardation, A for alopecia, P for pseudoanodontia, and O is for optic atrophy. Here I present a case of 10-year-old male child with Gapo syndrome in association with meningocephalitis, along with bilateral glaucoma and optic atrophy, short stature, complete anodontia, and abnormally thickened lingual frenulum born to a non-consanguineous marriage with history of similar features in the younger sibling, younger sister, but developmental and social demands of the child were appropriate for the age. Next slide. Yes. This was a 10-year-old male child, first born out of a non-consanguineous marriage, where the birth history was uneventful. Parents, after the age of 2 years, parents started noticing that there was no eruption of teeth, and there was gradual reduction in the eyesight of the child. So they took the child to the multiple ophthalmologists, but they could not figure out what was wrong with the child. The patient came to an ophthalmologist, which referred to me, stating that patient has got bilateral glaucoma and optic atrophy also, and he could not find out what is the cause of the optic atrophy. When my child came to me, I examined the child, and the child had short stature and weight of around 23 kg, which was normal, which was low as per the child's data percentile. Examination of the face and neck region revealed the typical species of Gapo syndrome, with thickened skins with high-end frontal bossing was seen. There were prominent scalp veins, sparse scalp hairs were seen, eyebrows, there was medulosis also, eyelashes, and there was low set ears also. The most striking feature in the patient was there was thickened lingual. So in the next slide. So this is the typical facies. When the child came to me, initially I thought it could be some form of progeria. I was looking for in the literature regarding the cases of progeria and their differentials, and I came with this entity, Gapo syndrome. This is classical typical facies of the first image is showing classical typical facies of the Gapo syndrome patients. Second image showing this pseudoenodontia. There is no eruption of teeth. On performing the orthopantomogram, there were non-erupted teeth inside the jaw. The third image is showing the thickened frenulum. Fourth is showing the craniosynostosis. Fifth image is showing sparse hairs, even eyebrows are sparse. There was low set hairline, low set ears, and even the veins were thickened. MRI was absolutely normal. There was no parenchymal injury, or there was no birth asphyxia, any sort of that. Next slide. So the basic discussion is Gapo syndrome is an autosomal recessive entity. Although I tried to find out whether there is consanguinity of any degree, but there was no consanguinity. They were totally different, belonging to the parents were belonging to totally different families. So that was a non-consanguineous marriage. The Gapo syndrome occurs because of the gene anthrax toxin receptor gene ANTXR1 gene, and its homozygous mutation leads to this entity. Diagnosis mostly relies on the physical examination. Actually, I wanted to do the genetic testing also, but because of financial constraints, I could not do the genetic testing. But diagnosis is most likely based on the physical examination of the patient. There is no definite curative treatment, and the Gapo patients are reported to have reduced lifespan, and they die in around 4 to 6 decades of life.
Okay, thank you, Dr. Abbas. Tell me one thing, that this is the only case reported in literature also before that?
No, sir. So whatever I have reported, this is the 47th case in the literature. Actually, this belongs to a pediatric age group. In pediatric age, there are multiple syndromes with craniofacial abnormalities, mid-facial hypoplasias, craniosynostosis, but still it has been missed.
That may be associated with that.
Both in the ophthalmic and both in the pediatric. Yes, sir.
Who is this?
Next is
Dr.
Shishir Pandey.
Shirish Pandey.
Good afternoon, respected judges. I am presenting an isolated posterior cerebellar artery dissection in a 12-year-old, a rare entity as a case report. Regarding the case history, there is a 12-year-old boy with a normal developmental history and a no significant past history, presented to the emergency room of our hospital with a complaint of diminution of vision since 4 days, which was sudden in onset, started while he was playing. Vision problem was in the form of difficulty in seeing objects towards the left, and it was associated with headache that was hospital in nature. He also reported an episode of sudden onset of numbness in the left side of the body, after which he could not stand unassisted and had a difficulty in holding object in the left hand, which lasts for about 45 minutes and resolved completely. On examination, there is a visual field defect in the form of left incongruous incomplete homonymous hemianopia with macular sparing. Rest of general physical and neurological examination was unremarkable. Evaluation for coagulopathy and cardiac source of embolism was negative. This is the MRI brain. It shows a diffusion restriction in the right occipitotemporal lobe and the adjoining part of the thalamus, which is consistent with a right PCA territory infarct. And on the doing MR angio brain, there is a luminal narrowing and effacement of the proximal portion of the right-sided PCA, and there is also effacement of the distal branches. And on doing a cerebral DSA, there is a right PCA incomplete filling at a junction of P1 P2 segment, and there is an incomplete filling in the territorial supply of the right PCA. And on further cerebral DSA, there is a distal filling of PCA by PCMC collateral territory in the late phase of internal carotid artery angiogram. Actually, there is this is a late phase of internal carotid artery angiogram, in which there we can see a collaterals from the MCA is filling out the collaterals of the PCA territory, and there is an absence of an fetal PCA, which could also be searched in the cause of if there is an isolated PCA infarct. This is the 3D reconstruction image of the DSA, which showing right PCA luminal narrowing at a P1 and P2 junction. Patient was managed with antiplatelet in the form of aspirin, and patient responded to the treatment well and reported improvement in the visual field defect on the further follow-up. This is the follow-up MRI, which shows the reduction in the size of the area of the infarct. And then the question arises why this case is important. Actually, the extracranial and intracranial arterial dissection is a recognized etiology for a stroke in the young. And most intracranial arterial dissection involve the vertebrobasilar system, and to a lesser extent, the middle and the anterior cerebral arteries. Isolated dissection involving the posterior cerebral artery is extremely uncommon. Etiology which has to be ruled out in case of a isolated PCA infarct is syphilis, migraine headaches, cystic medial necrosis, Marfan syndrome, mixed connective tissue disease, fibromuscular dysplasia, homocystinuria, polycystic kidney disease, and trauma. The most common symptom of a vertebrobasilar and the PCA dissection is still the headache. The dissection of intracranial aneurysm usually present with a large cerebral infarct and may be associated with a subarachnoid hemorrhage. But in case of isolated PCA dissection, it behaves more a benign clinical entity. The transient hemisensory symptoms that was encountered in our patient, which is attributed to the lesion proximal and before the thalamico-geniculate and the posterior choroidal artery branches that supply the thalamus. The infarct that developed in this patient was most likely in the territory supplied by the lateral posterior choroidal artery, as well as in the occipital and the temporal lobe territory supplied by the PCA, which is a causative of this hemianopic symptoms. Isolated PCA dissection is the most common site, that is P1 and P2 junction, which was seen as in our case, which is close to the free border of the tentorium cerebellum. It has been suggested that the traumatic aneurysm, including dissection, may occur in the mild head trauma secondary to the stretch or shear injury of the vessel. Although there was no such history, but the symptoms occurs after when the child was gone for playing. Maybe that trivial trauma can cause this thing. And the diagnosis of intracranial dissection and dissecting aneurysm is predominantly made by DSA, which remains the gold standard technique. Because in MR angiography is limited by the small of the motion artifact. Regarding treatment part, anticoagulation is the recommended treatment for extracranial arterial dissection. But its use in the intracranial arterial dissection, as in our case, is debated because of potential risk of mural hemorrhage, rupture, and extension of the lesion. That's why we are opted for a more conservative therapy in the form of antiplatelet. Patient with ruptured dissecting aneurysm and associated subarachnoid hemorrhage are definitely taken for the surgical and endovascular means. Surgical options available are trapping, proximal ligation, reinforcement with or without intracranial or extracranial bypass. Repeated intramural hemorrhage or enlargement of associated aneurysm with the dissection also requires surgical intervention. Endovascular options are stent placement or therapeutic occlusion by using a detachable microcoils or balloons. In the last, the take-home message is that DSA has to be performed in all young cases of posterior circulation stroke, as arterial dissection is an important differential. And MR angiography underestimate the lesion in the posterior circulation stroke, as in our case, MR angiography shows no flow in the proximal P2 segment, which falsely suggesting a lumen occlusion that is likely to be caused by an embolic event. That's why we have searched for this cardioembolic sources of infarct. And the antiplatelet treatment is recommended as a treatment of choice for this intracranial dissection. Thank you.
Okay, thank you, Dr. Shishir. Any question? Okay, thank you, Dr. Shishir. Now we move on to next speaker, Dr. Sapnil Jain. Will be speaking on human herpes virus HHV6 in an immunocompetent host.
Yes, sir. Are my slides visible?
No. Yeah,
just...
now it's visible. You are visible, but you're not your slides.
Okay, sir. I'll
share the screen.
I'll start the screen sharing again. Sir. Are they visible now, sir?
Yes, it is.
Yes. Good morning, good afternoon, everyone. I'm going to present a rare presentation of HHV6 encephalitis in immunocompetent patient. So HHV6 is a herpes virus that causes self-limiting syndrome known as roseola infantum in childhood. And similar to other herpes viruses, as once one gets exposed, they remain latent in the peripheral blood cells, neural cells, and other brain tissues for the lifetime. And thus, it may reactivate later due to immunosuppression. So there have been case studies and case reports that have reported HHV6 in febrile seizures, epilepsy, multiple sclerosis, and encephalitis, but such associations have rarely been reported in immunocompetent patients. So we will be reporting a HHV6 encephalitis in an immunocompetent patient. Our patient was an 18-year-old male patient. He was previously healthy and with insignificant past medical history. He presented with high-grade fevers in 7 days, followed by severe unrelenting holocranial headache, which was not responsive to analgesics, with recurrent bouts of projectile vomiting. On examination, he was conscious though irritable, slightly disoriented to time place, with slight neck rigidity, although other examination, neurological examination, as well as systemic examination, including ear discharge or mastoid swelling, was negative. So patient was admitted with a possibility of meningoencephalitis, and routine investigations were normal. And the serum infection screen, including COVID-19, malaria, and dengue, was also negative. So empirically, we started the patient on intravenous acyclovir, antibiotics, steroids, anti-epileptics, and other supportive care. And at that time, we performed an MRI, which did not reveal any significant abnormality, although the CSF analysis was CSF analysis revealed lymphocytic pleocytosis with a TLC of 240 and 100% lymphocytes, slightly elevated protein of 108 with a normal glucose level. Importantly, the CSF HHV6 was positive, while it was negative for other common meningoencephalitis pathogens, and it was negative for gene expert for tuberculosis and routine stains. So because the cultures also came negative, we stopped the antibiotics, continued with the antiviral. So the MRI images were completely normal. Because HHV6 is rarely reported in an immunocompetent patient, we went for evaluation of immunocompromised status in our patient, but that was completely negative. So patient showed some clinical improvement, although the second CSF analysis that we did 9 days after the first one showed some lymphocytic pleocytosis persistent with elevated protein, and HHV6 PCR was still positive. So we went to certain case reports and antiviral was changed from acyclovir to ganciclovir. And to our utter surprise, within the next 10 days, patient showed remarkable improvement in his clinical status with resolution of all the clinical features with a negative CSF PCR for HHV6 when we did the CSF PCR repeat after 10 days of the second analysis. So patient was discharged on oral valganciclovir for 10 days, and follow-up, patient was clinically stable and having excelled in his engineering entrance within a few days of his discharge from the hospital. So the pathogenesis of HHV6 meningoencephalitis is still incompletely understood, and probably like other herpes viruses, it is probably due to viral reactivation, induction of CD4 lymphocytes, and downregulation of IL-2. The published case reports do not mention any particular clinical differentiating feature or any particular neuroimaging feature, although most of the case reports have reported that MRI is usually normal. And the only way of diagnosis is CSF HHV6 DNA PCR. Treatment again is not guideline and the prognosis is variable, but in vitro studies have found ganciclovir to be preferred over acyclovir, and the total duration of therapy in most case reports and case series has been recommended for at least 3 to 4 weeks, and followed by a valganciclovir oral therapy for 1 to 2 weeks. So the important differential diagnoses are meningoencephalitis due to more usual pathogens, autoimmune or paraneoplastic encephalitis that we didn't evaluate because the patient was improving with antivirals. So HHV6 is a rare cause of meningoencephalitis in immunocompetent patients with no known clinical distinguishing features, as is the case with most viral encephalitis, but it should be suspected particularly in patients with initial negative evaluation for usual pathogens, because it is, as in our case, quite wonderfully responsive to ganciclovir. And although additional studies are still required to understand the underlying mechanism of encephalitis in such patients, because few studies have shown that HHV6 PCR may be positive as a false positive in normal individuals. Thank you.
Okay. Thank you, Dr. Swapnil. Dr. Kiran
Dr.
Bala, you are coming.
Swapnil,
Yeah.
Yes, ma'am.
do you do this HHV6 PCR in routine?
Yes, ma'am. Actually, we have a meningoencephalitis panel in which there are a lot number of organisms that we detect on PCR. So there is a herpes panel in which not only we look for herpes simplex and herpes zoster, we also look for other rare herpes viruses like Epstein-Barr and HHV6.
So you send for viral panel.
Encephalitis panel, yes, ma'am.
That's why you could get it. Because otherwise in routine setup, we are not doing HHV6.
Yes, ma'am. Actually, it is quite, it does not have any particular differentiating clinical features. Some case reports have shown that it might involve the temporal lobe, similar to the HSV1 and HSV2. But that is why we need a suspicion, because the antibiotic the better antibiotic would be ganciclovir rather than acyclovir. So the response to ganciclovir is better than acyclovir. So we can evaluate for HHV6.
Okay, thank you.
Okay, thank you, Dr. Swapnil. Now we move on to the next speaker, Dr. Agrata Sharma. Will be speaking on neuromyelitis optica spectrum disorder, presenting as alexia without agraphia. Agrata Sharma, are you there?
Dr. Agrata?
I think she's not there.
So we can
Continue.
call the next.
The next is our next speaker. May I invite Dr. Raghav Kapoor? Dr. Raghav Kapoor. Yeah, I can see on the screen.
Yes, am I audible?
You are audible, but your video is not audible.
Now you are visible.
Okay, yeah, sure. Now you have come.
Are my slides visible, sir?
No, you share. Yeah, it's visible now.
Good afternoon, everybody. My talk would be on diagnostic and prognostic significance of CSF CPK in meningitis. CPK, an enzyme involved in the phosphorylation of creatinine with ATP from ADP and creatinine phosphate, is markedly elevated in meningitis of varied etiology. Out of the CPK enzymes, CPK-BB brain type was found to be more specifically raised in infections of the central nervous system. The liberation of CPK-BB from the brain tissue and its penetration into the intercellular fluid and then into the CSF was related to functional and structural changes in the cellular membranes of the brain and meningitis. So here in this figure, you can see in the skeletal muscle and myocardium, CPK-MM is the predominant isoenzyme of CPK. However, in the brain, we have CPK-BB. So we did a simple observational prospective study of about 40 cases of meningitis, where we derived CSF and serum samples of CPK, and simultaneously to compare, we did CSF and serum samples of normal patients who were posted for surgery and were undergoing spinal anesthesia. So what we found was we had a total 12 cases of pyogenic meningitis, 20 cases of tubercular meningitis, and 8 cases of viral meningitis. Here we can see that in serum, the CPK values were near normal. However, they were markedly elevated in pyogenic meningitis and also in tubercular and viral meningitis. These values were raised. So what we could infer was that CSF CPK can predict there is some infection in the brain. However, it cannot significantly tell us that what infection is there. Then we had, depending on the sensorium, in conscious patients, the mean CSF CPK was less than that of that in the patients who were unconscious, that value being more than 600. And out of total 40 cases, 10 of them could not make it. So in there we clubbed the CSF CPK as more than 600 or less than 600. So if the CSF CPK was less than 600, 3 out of the 30 cases expired, giving a mortality percentage of 10, whereas this was 70% if the CPK was more than 600 in the CSF. So there was a direct relationship with CSF CPK level and mortality. To conclude, we can say that CSF CPK is not elevated in all cases of meningitis. It is not possible to differentiate the type of meningitis on the basis of enzymatic activity in any of them. However, it is
You're not
possible.
audible.
Hello.
Not audible, please.
Please.
Am I audible, sir?
No,
No,
he's
no,
audible.
you are.
Yes, you are audible.
Okay. To conclude, we say that CSF CPK can tell us that there is some infection in the brain. It can't distinguish as to what infection is there. So diagnostic significance of CSF CPK is not very high, but it is able to tell us the prognosis. So it is possible to assess the degree of brain damage and predict prognosis because higher basal activity of this enzyme is associated with a poorer prognosis. And it has a direct relationship with the level of consciousness of the patient at the time of admission, and it can tell us about the mortality. That's all. Thank you.
Okay. Thank you, Dr. Raghav. Any comment? Any question?
Dr. Raghav, what does literature say? How significant is this to look for the CSF CPK?
Ma'am, I reviewed a couple of articles. So I found 3 articles with the similar studies. So they can't diagnose that what meningitis is there. Like we found like it was around 600 in cases of pyogenic meningitis because the patients are more toxic. But there the p values are not very significant. But the prognosis in terms of mortality and level of consciousness is there that the patients who are more sick have higher CSF CPK values. And this is not very significant when it comes to the serum, because in serum, the CPK values are normal in meningitis.
Yeah, that's expected to be normal CSF. Oh, sorry, serum.
In the serum.
Okay.
Thank
you, Dr. Raghav. Is Dr. Agrita has come? Has she come? No. we are marking an absent. Now we move on to next speaker is Dr. Ankita Desai. Will be
Hello.
speaking on. Hello,
Yes, sir. Am I audible?
Dr. Ankita.
Yes, sir.
You will be speaking. Yeah, audible. You share your screen.
Yes, sir. Oh, shit. Yes. Hello.
Yeah, you share
Yeah,
your
you
screen.
are audible.
There is a problem with Zoom. Just a minute. Hello.
Yeah.
Hello.
Screen is not visible.
Yes, sir.
Yeah, now you are visible. Yeah.
Am I visible?
Share your screen.
Yes, sir. Is it visible, sir?
Yeah.
Yes.
No, no.
Make
Yeah,
it
now it is.
full screen.
Yeah, now it is. Now it is. Make it slide
Okay.
show.
Put it on
Yes,
slide
yes.
share mode.
Now is
Yeah,
it visible?
okay.
Yes.
Yeah.
Good evening, sir, ma'am. My presentation topic is clinico-radiological and histopathological correlation of the midline posterior fossa tumor in pediatric population. I am a senior resident, MCH neurosurgery. Background: the incidence of the tumor, CNS tumor in pediatric population is 20%, and which is the leading cause of the solid cancer-related deaths in the children. Out of which 60% of these tumors occurs below tentorium, including the brainstem, cerebellum, fourth ventricle, and CP angle. The most common posterior fossa tumors are medulloblastoma, ependymoma, astrocytoma, and pilocytic astrocytomas. Clinico-radiological diagnosis based on radiology and clinical grounds may not be same as the post-operative histopathological diagnosis. So the aim of the study is to clinical and radiological features study and accuracy of the diagnosis based on it of patients between the 9 months of age to the 16th year of age having midline posterior fossa mass lesion, and diagnosis is based on clinical and radiological features. The materials and methods were: the study design is a prospective observational study which included the 25 children aged between the 9 months to 16 years with the midline posterior fossa tumors. The exclusion criteria were cervicomedullary lesions, the extraaxial lesions in posterior fossa. The cases were reviewed with CT and CE-MRI findings at the time of initial presentation, the demographic profile of the patient, clinical findings at the time of initial presentation, and the final histopathological impression. My study results are on a combined clinico-radiological diagnosis. The most common diagnosis made were medulloblastoma and pilocytic astrocytoma in equal frequency, that is 40%, with ependymoma being the third in position, that is 16% of the patient, with the choroid plexus papilloma in 4% of the patient. The clinical diagnosis was correct in 64% of the patients, whereas the radiological diagnosis separately was correct in 84% of the patients. So radiological diagnosis was more near to the final diagnosis, but the combined diagnosis has reduced. So here in correct diagnosis in medulloblastoma, we were able to correctly diagnose the 8 patients out of 11 patients, that is 47.1% out of 100% we were able to diagnose correctly. In case of pilocytic astrocytoma, it is same. Ependymoma was diagnosed in one patient out of 4 patients, which was pre-operatively diagnosed as ependymoma. Atypical rhabdoid tumor was not included in the diagnosis. It was very rare, but it was present in histopathological report in one patient. So the total out of 25 patients, only 17 patients were diagnosed correctly on the basis of clinical and radiological findings. Hello. Yes. The conclusion: the pre-operative correct diagnosis of the medulloblastoma and pilocytic astrocytoma can be done correctly in a significantly higher number of cases where pre-operative correct diagnosis of ependymoma and atypical rhabdoid tumor were done in insignificantly lesser number of cases. So we can rely on the clinical and radiological diagnosis for the pre-operative planning of these tumor for further management, whereas ependymomas and atypical rhabdoid tumors, which are less common, and choroid plexus papilloma, reliability is less. Plain CT characteristics along with the plain plus gadolinium contrast enhanced MRI can be used to distinguish between the medulloblastoma, ependymoma, pilocytic astrocytoma with reasonable accuracy. Thank you.
Thank you, Dr. Anita. Dr. Ankita. Anyway, have you heard the name of radiogenomics?
Sorry, sir?
Radiogenomics. Because the subclassification of medulloblastoma also. Because on MRI you have diagnosed medulloblastoma 84 with 84% specificity.
Yes,
but
sir.
if you go for radiogenomics, you can come out with a WNT type, SS hard type.
Yes, sir. Actually, I have not included it or have no
So
information.
now people are coming with the radiogenomics also.
Yes, sir.
So which give you pre-operative diagnosis, genetic diagnosis also of the medulloblastoma, the posterior fossa tumors in children.
Yes, sir.
Any question? Any comment from the audiences, please? Okay, thank you, Dr. Ankita.
Thank you, sir.
Nice presentation.
Thank you, sir.
So this was the last presentation.
Yeah, this was last presentation. Yeah.
Yes.
So thank you all the speakers and thank you all my colleagues and chairpersons and the organizers for organizing such a wonderful session. Thank you very much. Now we move on to next.
Thank you, sir. Thank you.
Session. Yeah.
Now I thank honorable judges, Dr. Kiran Bala ma'am, Dr. A.K. Srivastav sir, Dr. Sunit Mediratta sir, Dr. Rajendra Singla sir. With this, we are ending the session in Hall B. I request all to please join in Hall A. I also request honorable judges to share your score of the candidates to us. Thank you.
How to share?
Sir, you can WhatsApp us, sir.
WhatsApp now. Okay, WhatsApp.
Yes, sir.
By evening, because I am busy right now.
Yes, sir. Whenever you are comfortable.
Okay. Thank you.
Thank you, sir. Thank you. Thank you, ma'am.
Thank you. Thank you, everybody.
Thank you, Dr. Kiran
Enjoyed the
Bala.
session. Thank you.
Okay, bye.